Here on 107.9 FM.
Right. It's not raining. Good. What? I've forgotten. Should I?
Just both sit down. Just both sit down.
Yeah. Right. Oh, that way. I don't know what. Oh, I don't know. Could you please? It's my list. Should I go? I don't know quite what. Oh dear. Chicken cheese.
What?
Chicken cheese?
Sorry.
Oh. Oh. I don't know. People with dementia have experiences like this every day.
So, good day everyone. I am PGI Arellano, and together with my co-PGIs, Benito, Espanada, Gandamra, Maslamama, Solatorio, Torion, and Tortugo, we will be discussing about dementia, also known as major neurocognitive disorder. So, what is dementia? Dementia refers to a disease process marked by progressive cognitive impairment in clear consciousness. The cognitive deficits in this disorder represent a decline from a previous level of functioning. It is critical that the cause is identified and subsequently worked up, since this disorder can be progressive or static, and it can be permanent or reversible. Later on, the different causes of dementia will be discussed.
For the epidemiology of dementia, the prevalence of dementia is rising with the aging population. The prevalence of moderate to severe dementia in different population groups is approximately 5% in the general population older than 65 years of age, 20 to 40% in the general population older than 85 years of age, and 50% in chronic care facilities. Of all patients with dementia, 50 to 60% have the most common type of dementia, the dementia of Alzheimer's type. Dementia of the Alzheimer's type increases in prevalence with increasing age. For persons aged 65 years, men have a prevalence rate of 0.6% and women of 0.8%. At age 90, rates are already 21% for both sexes. Patients with dementia of the Alzheimer's type occupy more than 50% of nursing home beds. More than 2 million persons with dementia are cared for in these homes. Now, the second most common type of dementia is vascular dementia, which is causally related to cerebrovascular diseases. Hypertension predisposes a person to the disease. Vascular dementia accounts for 15 to 30% of all dementia cases. Approximately 10 to 15% of patients have coexisting vascular dementia and dementia of the Alzheimer's type. Because dementia is a fairly general syndrome, it has many causes, including head trauma, alcohol-related dementias, and clinicians must embark on a careful clinical workup of a patient with dementia to establish its cause.
The cause of dementia will vary among person depending on the type of brain changes. Mostly the cause is unknown. So we will discuss the most common cause of dementia in ages 65 years old and above. So lots of disorders contribute for a person to develop dementia. We have what we call the neurodegenerative diseases, the Alzheimer's disease, the vascular dementia, and the mixed vascular and Alzheimer's dementia. So these are the type of disorders that affects the normal brain functioning that leads to deteriorating or loss of normal brain function. So we have the common causes of dementia. We have the generative dementia, we have psychiatric, physiologic, metabolic, tumor, traumatic, infection, cardiac, vascular, and anoxia, demyelinating diseases, and the drugs and toxins. So first, we will tackle about the Alzheimer's type dementia. So it is the most common type of dementia in ages 65 years old and above. So the hallmark of this dementia is the abnormal buildup of proteins of what we call the amyloid deposits or plaques or your tau tangles that will lead to changes of the normal brain functioning. So the vascular dementia is the most common type of dementia in male persons who have comorbidities such as hypertension and cardiovascular diseases. So it will lead to a damage on your brain's vessels that will cause an interruption of the blood flow and oxygen to the brain. So the last type is the mixed dementia. So it is a combination of two or more types of dementia such as your Alzheimer's type and your vascular type dementia.
For the clinical features, clinicians should note patients' complaints about the following: intellectual impairment and forgetfulness, as well as evidence of patients' evasion, denial, or rationalization aimed at concealing cognitive deficits. Excessive orderliness, social withdrawal, or a tendency to relate events in a minute detail can be characteristic, and sudden outbursts of anger or sarcasm can occur. Patients' appearance and behavior should be observed. Lability of emotions, sloping grooming, uninhibited remarks, silly jokes, or a dull, apathetic, or vacuous facial expression and manner suggest the presence of dementia, especially when coupled with memory impairment. Memory impairment is typically an early and prominent feature in dementia, especially in dementia involving the cortex, such as dementia of the Alzheimer's type. Early in the course of dementia, memory impairment is mild and usually most marked for recent events. People forget telephone numbers, conversation, and events of the day. As the course of dementia progresses, memory impairment becomes severe, and only the earliest learned information, such as the person's place of birth, is retained.
DSM-5, dementia is called major neurocognitive disorder. And because dementia is not one disease but several, diagnosing dementia is a two-step process. First, you need to determine whether dementia is present or not. If it is, then you need to determine what type of dementia it is. We can answer the first question by using the diagnostic criteria in the DSM. The criteria for major neurocognitive disorder are quite simple and can be captured in the mnemonic DIAR, which stands for decline in cognition, impairment, rule out delirium, exclude mental disorders. First, there's need to be a clear decline in cognition. Most often, this takes the form of memory loss, although other cognitive domains such as language, attention, and the ability to plan are often impacted as well. In clinical settings, a variety of bedside tests, including the Mini Mental State Exam and the Montreal Cognitive Assessment, can be used to provide a standardized assessment of various cognitive domains. This can be helpful not only for establishing the initial diagnosis, but also for tracking progression over time. Next, these cognitive deficits must be severe enough that they lead to functional impairment. In early stages of dementia, this is the first noticeable when it comes to instrumental activities of daily living, which are more complex tasks such as shopping, housekeeping, accounting, food preparation, and transportation. You can remember this using the acronym SHAFT. As dementia progresses, impairment is seen in even more fundamental areas, known as activity of daily living, which are basic self-care tasks that a person must do in order to survive. Example of this are when dressing, eating, ambulating, toileting, and hygiene. This will give us a structured way of assessing functional impairment. After establishing both cognitive decline and functional impairment, we need to rule out delirium as a possible cause. Delirium is an acute state of confusion that can present similarly with memory loss and other cognitive deficits. However, it is not permanent in the same way that dementia is, and will generally resolve once you've treated the underlying condition. Because of these major differences in both prognosis and treatment, ruling out delirium is essential. Finally, we need to make sure to exclude other psychiatric conditions like depression and schizophrenia as possible causes. These disorders can sometimes mimic dementia as well, especially in the elderly where symptoms like impaired concentration and lack of motivation can easily be mistaken for dementia. For the second question, what type of dementia is it, relies upon a good understanding of the different forms that dementia can take. The main forms to be aware of here are Alzheimer's disease, vascular dementia, dementia with Lewy bodies, and frontotemporal dementia.
For the differential diagnosis, classically, vascular dementia has been distinguished from dementia of Alzheimer's type by the decremental deterioration that accompanies cerebrovascular disease over time. In comparison with vascular dementia versus dementia of Alzheimer's type, vascular dementia has more focal neurological symptoms such as paralysis or body weakness, speech, vision, and hearing problems. And when comparing vascular dementia versus transient ischemic attacks, which is defined as brief episodes of focal neurologic dysfunction lasting less than 24 hours, and each episode lasts for 5 to 15 minutes. In transient ischemic attacks, symptoms are transient functional disturbance and it needs early medical intervention to prevent complications such as brain infarction. Delirium is distinguished by rapid onset, brief duration, cognitive impairment fluctuation during the course of the day, nocturnal exacerbations of symptoms, marked disturbance of sleep and wake cycle, and prominent disturbances in attention and perception. Some patients with depression have symptoms of cognitive impairment which are difficult to distinguish from symptoms of dementia. Patients with depression-related cognitive dysfunction generally have prominent depressive symptoms and often a history of depressive episodes. Persons who attempt to simulate memory loss as in factitious disorder do so in an erratic and inconsistent manner. In dementia, memory for time and place is lost before memory for person, and recent memory is lost before remote memory. Schizophrenia can be associated with some acquired intellectual impairment. Its symptoms are much less severe than are the related symptoms of psychosis and thought disorder seen in dementia. Normally, as we grow old, minor memory problems can occur. These are sometimes referred to as benign senescent forgetfulness, age-associated memory impairment, or normal benign age-related senescence, versus dementia. Age-associated memory impairment do not interfere significantly with a person's social or occupational behavior. Other disorders which are listed can manifest with memory impairment, but these are unlikely.
For the course and prognosis of dementia, the classic course is an onset in patients' 50s or 60s with gradual deterioration over 5 to 10 years. The average survival expectation for patients with dementia is approximately 8 years with a range of 1 to 20 years. The age of onset and the rapidity of deterioration vary among different types of dementia and within individual diagnostic categories. A rapid course is likely in patients with early onset dementia or with family history of dementia. A gradual onset of symptoms is associated with dementia of Alzheimer's type, vascular dementia, endocrinopathies, and brain tumors. Reversible dementias with symptom regression is noted in dementias caused by hypothyroidism and brain tumors, while incrementally worsening course is common in vascular dementia. In the terminal stages of the disease, patients present to be profoundly disoriented, incoherent, amnestic, and incontinent of their urine and feces.
For the treatment of dementia, The major goals of dementia management are to treat reversible causes and to provide comfort and support to the patient and caregivers. Treatment of underlying causes may include thyroid replacement for those with hypothyroidism, vitamin therapy for thiamine or B12 deficiency, antimicrobials for opportunistic infections, or antiretrovirals for those with HIV, ventricular shunting for NPH, or appropriate surgical, radiation, and or chemotherapeutic treatment for CNS neoplasms. For dementia medications, while these drugs are not designed to cure dementia or repair brain damage, they may help slow down progression and maintain mental function for a while longer. For the most common type, which is Alzheimer's dementia, memantine proves useful when treating some patients with moderate to severe Alzheimer's disease. Its major benefit relates to decreasing caregiver burden, most likely by decreasing resistance to dressing and grooming support. In moderate to severe Alzheimer's disease, the combination of memantine and a cholinesterase inhibitor such as donepezil, rivastigmine, galantamine delayed nursing home placement. Other treatments include lifestyle changes such as healthy diet, exercise, cognitive activities. Next is behavior therapy. The primary goal are to make the patient's life comfortable, uncomplicated, and safe. Preparing lists, schedules, calendars, and labels can be helpful in the early stages. It is also useful to stress familiar routines such as walks and simple physical exercises. And lastly, caregiver education and counseling.